Welcome back. It's a pity this is the last day of the course because there's still some restaurants I haven't visited yet, but I've now managed 3 different restaurants in this area, so I'll be writing a guidebook soon for visiting academics. What you need to know, where to go. Actually, I've been to 4. The other one was a bit further away, wasn't it? Good. Right, well, this is actually an example of social capital in a sort of way, I think. It was on a wall round the corner 5 minutes from my office, and somebody had just decided they would put this artwork there. It's made of plastic. Unfortunately, they've lost a leg. And also there's a thin attaching this sort of balloon or heart. And so for me, this to some extent summarizes the challenge of high-cost medicines. We want to hold on to our money, not because we just love money and want to count it and live with it. That money we use for other things. So we are worried about the cost of healthcare. But we also want to hold on to, well, the heart can be anything. It can be our health, or it could almost be our humanity. And our humanity says we should be caring for other people. And so what happens if you've got people with a serious condition, that you've got a drug that could help treat that condition, but the drug's expensive? How do you get pulled in different directions? You're worried about the cost, but you want to hold on to the health and everything else. So that's where this character comes from. As you can see, I spend all my spare time walking the streets looking for photo opportunities for lectures. One part of my waking, my attention is looking for these things. One I found in Japan, which I think is a rather interesting one on information and public health, is outside of police stations where they record accidents. I think it's in the last 24 hours. And also, I don't know if the red is a fatality or just a serious injury, but you've got the number of accidents and the number of injuries, which I find it's interesting. It's a sort of quite a low-cost public health intervention. We were just discussing about, are all interventions expensive, and maybe that's fairly cheap. Of course, what you could do is set up a trial. So in some areas you don't show the information, in other areas you do show it, and then try and establish if there's a link to accidents. But anyway, that's another topic. Right, so facing the challenge of high-cost medicines. And remember the link from this morning. If you're not going to leave it to the marketplace, you've got to have some sort of mechanism for making these decisions about which medicines will be adopted, which won't be. Now, of course, you could have processes or procedures which don't involve any economics. And historically, a lot of decisions in healthcare haven't involved economics. Historically, they haven't even involved evidence. Whichever man in the room has got the greyest hair, or shouts loudest, I'm being a little bit cynical here, but committees, seniority and deference to seniority. It's taken years for evidence-based medicine to try and replace that, I think. And in more recent years, as well as evidence-based medicine, I think we must look at both clinical effectiveness and cost effectiveness. So that's what I'm going to talk about now. This won't come as news to you. New medicines are generally costly. And over time, that cost is increasing. Naturally, patients and clinicians want access to these new medicines. Clinicians want to do the best for their patients, I assume. The patients will almost try anything, if the condition's serious, will almost try anything to get some relief of it. The pharmaceutical industry and those governments involved in decision making over new drugs are quite keen to get more rapid decisions. For the industry, it's very clear that if you think you've got a good product and you're time limited in terms of patent protection, you want to get it out there. You want to get it used. After all, your job is to make money for your stockholders. Government, well, they want rapid decision making for many reasons. One, they don't want the media complaining. They don't want patient groups on television criticising the government. But more than that, the government also want to improve people's health. And you don't necessarily improve health by denying treatment. If you've got a good treatment that represents reasonable value for money as well, you want to get it out there quickly because there's people out there who could benefit. Why delay? And so we're seeing a push in recent years towards more rapid decision making. And the regulators have joined in. So FDA and EMA, I can't speak for Japan here, but it might be the same. The regulators in Europe and America are trying to speed up decision making. So they've introduced all sorts of new schemes where they give a sort of fast track approval to some particular drugs. New drugs, sometimes it seems as if we have an expression in English, if you're waiting for a bus, it's always the case that you wait a long time, then 3 come along at the same time. And of course, you can only get on one of them. It's almost like that with drugs. You might, in some therapeutic areas, be waiting many years for a new drug, and then suddenly, in quick succession, you've got a series of drugs, treatments that have come along. Now this causes some real challenges for evaluation, which I'll be trying to highlight. And so, this idea of drugs coming along in clusters, this idea of the regulators wanting to make approval decisions earlier, more rapid decision making, this is actually leading us sometimes to have poorer evidence of clinical effectiveness, not better evidence. So we might be more ready to use evidence in our decision making, but paradoxically, in some of these clinical areas, we're getting poorer evidence because we're having to make a decision at an earlier and earlier stage about the merits of particular technologies. I like this table. It's from JAMA Oncology in 2015. What they looked at was 20 oncologic drugs that were approved by the FDA, the Food and Drug Administration, in the US between 2009 and 2013. You may know some of these names. At one time or another, I've probably been trying to evaluate them all. This is the cost per year of treatment, these numbers. They are in US dollars, but by any standard, these are quite big numbers. Now, these are not, let me say, drugs for necessarily a very rare condition, for just a very small patient group. All right, the patient group may not be huge, but it's sizable numbers of patients. And these are really quite high costs. More than that, it appears, while the costs are going up, the benefit we're getting relative to that cost is declining. So this is a study actually in an economic journal for a change, and again looking at cancer drugs, again launched in the US. They identified 58 drugs launched in the US between 1995 and 2013. And they worked out what the relationship between additional cost was of these drugs and the additional benefit, just measured in terms of additional years of life. Now that, of course, is a narrow measure of benefit, but it's a measure of benefit. So they're looking at how much the healthcare insurers were having to pay to get additional years of life using these cancer therapies. And what they found was in 1995, it was about $54,000. By 2005, this had risen to $139,000, paying to get an additional year of life. And by 2013, it had gone to over $200,000. And so this is very clear evidence, at least in the area of cancer therapies, we're getting less and less for our money. With that newer therapies, they may be improving health, but the amount we're having to pay for each unit of improvement, measuring it here as years of life, the amount we're having to pay is going up and up. In this paper, it's quite interesting. They argue there's quite strong incentives to set high prices. And it's partly to do with something in economics called elasticity of demand. I won't go into elasticity of demand, but basically, in the US, there's relatively little resistance to high prices for new drugs. There's a number of reasons for this, but I won't go into that. By contrast, in Europe, there is quite a lot of resistance to paying the high prices, and so these authors actually suggest the high prices in the United States are to some extent due to the less high, but still high, prices in Europe. So the manufacturer is essentially charging what they can in the different markets. And so the data I've just shown you in these two tables is very much US prices. Prices in Japan will typically be less, and prices in Europe will typically be less. But the phenomenon of high-cost drugs and getting less benefit for our money, that's global.